A very good morning to all, and my thanks to Dr. Sandeep Jasuja for this lovely meeting. So my role over here is to speak on PARP inhibition in the adjuvant setting in breast cancer. There is some excitement which has come after the Olympia trial. Okay, so this bit of basic science, we all know that BRCA1 and 2 are proteins which are supposed to, timely, and they're responsible for accurate repair of double-stranded breaks, which happen in DNA, and they maintain genomic stability. So they're part of the homologous recombination, and they result in genetic stability. So if there is a genetic instability at the fork, replication fork, these enzymes act. And if in case they are deficient, the PARP enzyme takes the lead. And if we talk about synthetic lethality, which we know that we've been using it for some time now, PARP inhibition would actually knock off the second repair mechanism as well. And therefore, the cell would undergo apoptosis, and this has been harnessed for quite some time. So talking about PARP inhibitor in adjuvant setting, and the evidence is Olympia trial, a phase 3 trial, with the trial design something like this, that here the genetic screening was done on the patients by Myriad Genetics, and for BRCA1 and 2 mutation. And the subgroup taken was basically neoadjuvant group and the adjuvant group as well. So in the neoadjuvant group, the triple negative breast cancer group should not have attained a PCR. So a non-PCR was taken in the triple negative in the neoadjuvant group. If it was hormone receptor positive, then a non-PCR and a CPS plus ERG score more than or equal to 3. Now, this is a new terminology. EG score, CPS EG score, which I would talk in the next slide. And the patient should have received more than 6 cycles of neoadjuvant chemotherapy, surgery, and radiotherapy would have been done. In the adjuvant group, in triple negative breast cancer, it should be a more than at least a PT2, or if a node is positive. In hormone positive, at least 4 or more nodes were positive. That is a N2 subtype. So again, the treatment modality, surgery, adjuvant chemotherapy, more than 6 cycles should have been done. So here they were randomized into 1:1 with olaparib versus placebo, olaparib at 300 mg BD given for a year, with the primary endpoint being looked upon as IDFS, and the stepwise analysis was done, where the first, if the primary endpoint being achieved, the secondary endpoints were looked upon, the secondary endpoints being distance, disease-free survival, overall survival, BRCA1 and 2 associated cancers, and safety analysis. Now, concurrent adjuvant therapy, including the endocrine therapy, was allowed along with olaparib if in case if the patient was ER positive. So if we look at the baseline population over here, and we see that BRCA1 is actually a major. So BRCA1 is the major subtype over here, as you can see, with nearly 71% of the patients. And if you see the age group, this is a relatively younger age group, 42 years. A prior neoadjuvant, adjuvant, or neoadjuvant was almost equally divided. And predominantly, this was a premenopausal, as they were mostly young patients. Now, talking about this particular thing of CPS plus EG score, especially in hormone-positive patients, where after neoadjuvant therapy, these CPS EG scores was taken, and this is a new terminology, which is nothing but clinical stage, pathological stage, and receptor status, and nuclear grade, not the actual grade, not the histological grade, but the nuclear grade were included. And this is a point system. It has been validated earlier in clinical trials in ER positive breast cancer post chemotherapy, the residue, and it has been found that it is impacting upon the survival. So this particular score was additionally taken in the neoadjuvant hormone positive population. Talking about the results, the primary endpoint was invasive recurrence or death, and this was actually reduced with olaparib addition versus placebo. So there was, in the first cutoff analysis itself, the primary endpoint achieved its statistical value, and hazard ratio was 0.58. The updated analysis done at 4-year, the second data cutoff, the IDFS slightly went down. The IDFS delta, that is versus the control, did fall a percentage. The distance disease-free survival was 86.5%. So the primary endpoint and the distance disease-free survival, that was the secondary endpoint, did achieve the statistical significance on the first data cutoff, but the overall survival actually had not achieved its statistical significance. Now, talking about the IDFS, for this particular plot or subgroup analysis, all were favoring the IDFS. All the sub parameters were favoring IDFS. Now, the overall survival eventually in the second data cutoff achieved its clinical significance, and there was a 3.8% improvement of overall survival at 36 months. So the curve are not separating out in the overall survival initially, but at a later date, and this is what was the overall survival. So based on this, FDA was, the approval was there, and this is indicated for adjuvant treatment of adult patients with deleterious or suspected deleterious. So both, either it is there, BRCA1 or 2 as the mutation, or there is a suspected deleterious mutation in high-risk early breast cancer who have received adjuvant or neoadjuvant chemotherapy. Now, talking about the adverse effects, the most common one when we talk about olaparib is nausea and anemia, the chances of leukemic conversion. So if you look at this over here, nausea was, these are adjuvant therapies, and they require strict compliance, a year of compliance. So nausea was just 2%. That also decreased over a period of time. Anemia was reported as 1.8%, and this was at the most it was. So they were basically mostly mild and moderate in the olaparib arm. So anemia was the only grade 3 adverse event occurring in more than 5% of the patients, and a couple of patients requiring blood transfusions over there as well. So 1-year adjuvant olaparib arm maintained the global health, the quality of life issues versus the placebo, and that's so important again for compliance, for sticking to the drug for over a period of 1 year. So when we talk about these days biomarker testing for breast cancer, and Dr. Somshekhar did cover that BRCA testing over there. So I would say that BRCA testing is becoming important, not just for TNBC at any age. Now, for TNBC, it is at any age. Male patients with breast cancer who meet the criteria with personal or family history, and when considering olaparib as adjuvant therapy. And Ki-67, of course, becomes a differentiator if you are actually choosing for adjuvant abemaciclib. So this is what the current NCCN guideline have to say, that if in case it's ER positive, less than 45, all are for BRCA testing. So from patient's perspective, ER positive 46 to 50 year, greater than 1 primary breast cancer, or the first degree relative, more than 1 first degree relative or second degree relative with breast cancer, ovarian cancer, pancreatic or prostate. And if in case ER positive more than 51 year, and basically the dilemma starts over here. Would you really test BRCA in ER positive more than 51 year? But then if in case with the current treatment platform available, where you have olaparib and you have a high adjuvant, high burden disease or a poor prognostic factor in terms of nodal positivity, more than 4 nodes, then you can actually consider testing BRCA over there. And that has been included in NCCN guideline. Now, the thing is that testing beyond the age of 60 years, the negative predictive value for what the NCCN guidelines say is pretty high. It's approximately 99.7%. Greater than 50 years and not meeting NCCN has negative predictive value of 99.6%. So talking about post neoadjuvant high risk burden disease treatment options. So you have in triple negative capecitabine, and then you have the immunotherapy arm in triple negative now with the 522 keynote 522, and then you have in ER positive abemaciclib. And when there is olaparib now, how would you actually compare? And it's human tendency to compare, not a fair comparison always, but it's always an orange to apple comparison. You want to compare. So there will be cross trial comparison, CREATEX strategy or keynote 522 in triple negative. Talking about CREATEX strategy, so it was found that the IDFS was 69.8% over there, 69.8% at 5 years. And then there were 2 other trials, actually, GCAM Siboma. Now, there was a difference between these 2 strategies, the CREATEX and the Siboma strategy, where CREATEX actually had all the neoadjuvant given upfront, and they gave capecitabine only in the residue. In the Siboma strategy, they actually allowed around 30% of the patients to give to be given upfront surgery, and then it go for adjuvant, and in high nodal burden they gave actually the capecitabine. Here the CREATEX was positive in its primary and secondary endpoint of overall survival as well. But this GCAM Siboma found that there is no benefit of adding adjuvant capecitabine. Probably the 1/3 patients were actually in the adjuvant strategy also. But the thing is, something which is actually showing benefit should show whether it is adjuvant or neoadjuvant strategy. But the point over there was they also actually did take basal versus non-basal subgroup analysis, and they found there is some benefit in the non-basal subtype. Now we are talking about BRCA patients, and these are, as we know, the triple negatives are mostly basal over there. So probably you can conclude, one can conclude that olaparib could be the treatment of choice if you're looking at the basal subtype of triple negative versus capecitabine. Now, talking about olaparib versus pembrolizumab, again, very difficult comparison. This is an immunotherapy over there. And the DFS, EFS over there, 67% versus 56.8%, where there was no PCR. Probably you can argue for olaparib that there is no overall survival benefit yet shown for pembrolizumab. Time would tell. And one is actually eagerly looking for post-operative strategy of, pembrolizumab. It has been added in the neoadjuvant strategy, but one is actually looking for what to do, which patients to actually escalate your treatment, because it's all about choosing the bad risk ones. There have been no safety signals, and there have been trials of pembro plus olaparib, and there have been almost 42 trials ongoing in the combination study. There have been no safety signals so far. There was a Mediola study which actually combined olaparib with durvalumab, and there is no increase in toxicity of the combination. So probably it looks, one can think to consider combining this, but there is no evidence for now. In the ER subgroup, ER positive subgroup, the story gets tougher with abemaciclib comparison. There is a 31.3% reduction in the risk of disease recurrent-free survival. The absolute difference between the arm was 4.2% at 3 years. So quite similar as compared to olaparib. But then if you look at the abemaciclib study, the patient were randomized for abemaciclib even after 16 weeks. So probably there is a food for thought that you can probably finish your olaparib and then continue with abemaciclib. That's just, these are just conjectural things or a hypothesis. I'm not saying that one can do it in the clinic right now. So minority of patients in ER positive on Olympia, but germline BRCA ER positive clearly benefited. And the population was actually overlapping the monarchy. I would just conclude by this gentleman's presentation, what I read, Mark Robson, and he says that Olympia is clearly a practice-changing trial, olaparib to be offered in patients meeting the entry criteria. In TNBC, who do not achieve PCR after NAC, one should consider olaparib over capecitabine. And in TNBC, patients receiving neoadjuvant pembrolizumab as per KN 522 would favor using both the agents post-operatively in non-PCR patients. So again, this is expert opinion rather than you change your practice basis on this. In ER positive patients would favor sequential use of olaparib 1 year and abemaciclib 2 years for particularly high-risk patients. And if forced that you need to actually differentiate what do you want to do, you can consider favoring olaparib. And of course, genetic testing, which is one of the most important one, probably with Olympia strategy needs to be liberalized for women who meet Olympia entry criteria, but detection rate in women over 50 to 60 years who do not meet NCCN criteria is very low. Remember to test the appropriate ER positive patients, that is the high nodal burden disease. You should consider probably for the patient, and then once it comes positive, you can always relook at the family. So this would be the algorithm for now. And olaparib is definitely very much there if it's a BRCA mutation, adjuvant strategy. And of course, in clinics, we continue to do what we are doing for now. Thank you. Are there any questions? Yes, the time was up, so.
Thanks a lot, Dr. Bajpai. And our next speaker is